we're going to go ahead and introduce. This is Van Ingram. He's the Executive Director for the Kentucky Office of Drug Control Policy. Van joined ODCP in November of 2004, shortly after it was created, with the mission of coordinating Kentucky's substance abuse efforts in enforcement, treatment, prevention, and education. Van served with the Maysville, Kentucky Police Department for more than 23 years, the last 6 as Chief of Police. He is former president of the Kentucky Association of Chiefs of Police and was named Kentucky Chief of the Year in 2001. He is a former recipient of the Governor's Award for Outstanding Contribution to Law Enforcement, as well as the Melvin Shine Award for Distinguished Service to Kentucky Law Enforcement. Van is a certified law enforcement instructor and has trained officers across the state on a variety of topics, including community-oriented policing, case management, and Kentucky's substance abuse issues for chiefs, sheriffs, and command staff. He is a frequent speaker on a variety of substance abuse issues in both Kentucky and nationally. Please welcome Van Ingram.
One, two. Hello, can you hear me? All right. Well, good afternoon. Good to be here with you all. Let's give Matt another round of applause. That young man does a great job. I am so proud of our syringe exchange programs across the state. And I'll talk about it a little later, but when we passed the bill, I really thought Lexington, Louisville, maybe Northern Kentucky, we got syringe exchange programs in Knott County and Pikeville, places I never would have dreamed of. Thank you, too, for what you do. I know it's not easy working with people with opioid use disorder. My life in law enforcement, from my life here, married to a nurse for 35 years, I understand the challenge. Thank you for doing it, because not everybody wants to. I'll tell you, I'm glad to be here with you. I'm glad to be anywhere after the near-death experience I had this weekend. I'll share it with you if I got time for that. Take it just a minute. My wife and I love to ride horses. She's a lot better at it than I am. She showed horses as a kid, you know, but I like to ride too. And we get on this, we're getting on these horses. I get on mine, and man, as soon as I sit in the saddle, it's gone. And I'm screaming for her to help me because, like I said, she knows more about it than I do. So she ran around the pop machine and unplugged it, and then settled down. But up until that point, it was touch and go. What I'd like to do this afternoon is quickly go through, as just kind of a reminder of the things that we did in 2012 around House Bill 1. Then I want to get into what we passed in 2015 that allows people like Matt to do his job, and talk about some of the newest threats. Now, I'm not going to talk about House Bill 1, am I? I didn't send those slides. Let's just talk about it for a minute. 1,297 Kentuckians last year died of preventable death. The weight of that is with me every day, and I think about it every day. Hello? All right. And it's because our nation and our state has been overexposed to opioid medications. And not just by a little bit, by a lot. And it really was a perfect storm that started in the 90s with well-meaning prescribers getting not such good information. It started with the most aggressive marketing campaign that had ever been seen in the pharmaceutical industry. It started on a lot of people's part for all the right reasons. But we got to always weigh risk versus reward, and I don't think we did a very good job of that. And it started because we don't want to be responsible for our own health anymore. We want the physician to fix me. I don't want to worry about diet and exercise, just give me something. I'm in pain, you have to fix me. Well, maybe I should lose 50 pounds and exercise, but no, I want something. And a lot of different reasons like that brought us here. So in 2012, we started looking at this in a real serious way and said, what are some things we can do that at the end of the day will create a situation where when a person is prescribed an opioid for chronic non-cancer pain, that's a very careful, measured, deliberate decision made between a practitioner and a patient. That's the goal. Now, the bill had 14 chapters and did a lot of things, but at the end of the day, that's the goal. We had prescription monitoring programs are the greatest tool government ever gave to medicine. And said, here's something to help you. At our height here in Kentucky, we had 23% of our prescribers that actually had an account with our CASPR program. I'm not saying they use it regularly, I said they had an account. We tried education, we tried all kinds of ways to get that number up. We couldn't get it up. So we ended up requiring it, that every prescriber in Kentucky of controlled substance has to have an account and has to use it. That was a challenge. How many physicians do I have in the room? So I know how many people I need to duck from. That was the biggest thing prescribers were against in that whole bill. And today I have prescribers all over the state tell me, I didn't know I had some of these people in my practice. I didn't know the woman I'd been treated for 10 years was also getting controlled substances from another provider. It's the last thing I hear complaints about now, but at the time we were trying to pass the bill, it was a huge deal. We also, within House Bill 1, we required better coordination between the boards, Board of Medical Licensure and the Dental Board and the Nursing Board, and the Office of Inspector General and the law enforcement community. And that's really improved. The media tagged the bill the pill mill bill. As I said, it was 14 chapters long and only one chapter dealt with pain clinics or pill mills. Because that's what we were after. We weren't after pain clinics, we were after pill mills. There was about 76 in the state of Kentucky the night we passed that bill. 38 of them were non-physician owned. They were owned by entrepreneurs. And there was a big problem between the House and the Senate. The Senate wanted to grandfather those 38 in. The House didn't want to. I didn't want to. But we grandfathered those 38 in. Only 8 of them even asked to stay. The other 30 left in the middle of the night. Because we were requiring them to take third-party payers, and they wanted to be cash-only businesses. We were requiring that whoever the medical director is, has some background, certification, accreditation in pain management. Because what we were seeing was somebody at the end of their career deciding to get into pain management because you could pile up a lot of cash really fast in that field. But they didn't have any background or specialty in that. So it was just a few things that we required, but the 30 of them said no. Of that 8, I think 5 are left, and I think they're all pretty good practices. And the result of that was, looking at last year, prescribing of hydrocodone combination products down 21.5%. The prescribing of oxycodone products down 4.5%. Alprazolam down 18%. So the effect has been good. We got some results we wanted to get, but we still got such a long ways to go. Not just in Kentucky, but in this nation. That opioid problem brought us to heroin. The heroin problem is bringing us to other problems that we'll talk about. Overdose deaths in Kentucky, as I said, 1,087 in 2014. This year we jumped to 1,297. And it breaks my heart. That's 1,297 Kentucky families that lost somebody they cared about in a totally preventable death. Matt was talking about the Hep C, and we got some of the highest rates in the country of hepatitis C. I don't have to tell you about NAS because you already know about that. I will tell you that one Northern Kentucky hospital get so many overdoses they keep a gurney out by the door because people pull up in the parking lot and in the emergency bay and drop people off who are in an overdose. And they wanted to keep the gurney closer to deal with that. I got to update that number. It says 1,248, and then I got to update last month from the medical examiner's office and said, well, we had some more open cases, and now it's 1,297. I told them, don't call me back until you can lower that number. I'm getting tired of seeing that number rise. Of those, approximately 28% have heroin in their toxicology report. Approximately 34% have fentanyl in their toxicology report. The reason I say it that way, it's not a heroin overdose often. It's an overdose based on polydrug toxicity. They got heroin in their system, they got gabapentin, they got alprazolam, they got cannabis, they got alcohol, and none of them in levels enough to kill them, but the combination of that leads to the respiratory distress. So me and the media spar a lot when I say overdose, or heroin was present in 252 times, and they say, oh, that means we have 252 heroin overdose deaths. No, that's not what it means. It means it was in the toxicology report. Doesn't mean that there was a heroin death. So yeah, the overwhelming majority are polydrug. Where's heroin the most prevalent? Well, right here in Jefferson County, followed by Kenton, Fayette, Campbell, and Boone, the northern Kentucky area, and Lexington. That's not to say we don't have heroin issues in other parts of the state. The larger populations, of course, have more overdoses, and really the supply routes, the distribution routes of the drug were much more prevalent in our urban core than they are in rural areas. Fentanyl, same 5 counties, just mix them up a little bit. This is total heroin submissions through 2010 through May of this year. As you can see, we got our first spike in 2010, or 2011, I'm sorry, after OxyContin reformulated in 2010. We saw a spike in heroin use. Then when Opana changes their formulation in 2011, we see a little more heroin use. By 2013, you see we're going through the roof. In 2014, we're going to actually see that start to level off. And we'll talk about why that is in a little while. Here's something kind of interesting. The #1 demographic for overdose death last year, age 45 to 54. We only hear about the 20-year-olds and the 23-year-olds. I submit to you, these are people who've suffered with an opioid use disorder for a decade or longer. Many of them addicted through a legitimate medical need or became dependent through a legitimate medical need. That morphed into addiction, and now they're getting heroin on the streets. Because when the opioid takes over the brain, it has a mind of its own for sure. The next demographic is 35 to 44, and then 25 to 34. So not always the way we read it in the media and the way we perceive it to be a young person's problem. Fentanyl submissions, you see the huge jump starting in 2014 and 2015. When I finish this slide in 2016, I'll bet you it's going to be off the chart. A lot of people say to me, Van, you all passed that prescription drug bill and caused this heroin problem. Well, it's a little more complicated than that. This slide shows that heroin seizures along the southwest border quadrupled from 2008 to 2012. Now, I grant you the drug cartels are sophisticated, they're smart, they rival any Fortune 500 company. But I don't think that they sat down in Mexico and said, you know, I think that Ingram guy is going to try and get a bill passed in 4 years to do something about prescription drugs. We better increase our shipments of heroin in the United States. It's a lot more complicated than that. Than just, you did this and this caused that. I'll tell you that the largest money source for the cartels for 3 decades was marijuana. It was the drug they made the most cash from. We now have medical marijuana in 24 states. We have full recreation in 4 states in the District of Columbia. They're not going to let that profit go away. No way. We've got other products we can ship to the gringos up north. That slide's just also showing. This is from the DEA threat assessment in 2013, talking about how heroin importation was going to continue to increase. So how did we get here with this heroin problem? Well, the DEA put out a map in 2001 showing the highest 10 areas of the country by zip code for the prescribing of opioid painkillers. There was 1 zip code in Northern California. There was 1 zip code in South Florida, or 2 in South Florida. The other 7 were in Eastern Kentucky and West Virginia. We were ground zero for this entire epidemic. I don't know the factors that lay why exactly. I wished I did. Lots of people got lots of theories. But I believe Appalachia was targeted by some very slick folks to get people to ask for and physicians to prescribe OxyContin and similar drugs. So we have a long history of painkiller abuse. My friends at Operation Unite run a treatment hotline down in the 5th District of Kentucky. They said when they started the hotline in 2004, 1 out of 10 callers would say that they had used drugs intravenously. Today, that number is 10 out of 10 callers say they use their opioids intravenously. When you've got to the point in your addiction where you're melting down your pills, putting them in a liquid and shooting them into your arm, heroin's not much of a jump. It's kind of the next logical step, to be frank with you. So abuse deterrent formulations played a part in getting us where we are. Greater awareness on the part of prescribers, because we are prescribing less. And as I mentioned, established drug cartels recognizing the demand. Because there are 4 things that are always going to impact the abuse of a substance. Price, can I afford it? Availability, can I find it? Perception of risk, am I afraid of it? Or am I afraid of the consequences? And the public attitude towards it. That's what got us in this mess with opioids, because all those things were there. There was a low perception of risk. Nobody thought you were bad because it's medication. And it was available, and insurance and Medicaid paid for it. But now we got a game changer. I told you about the cartels and their profit-driven. Prince got addicted to Percocet due to a legitimate injury, legitimate pain. He died of a fentanyl overdose. I don't know this, but what I suspect was his physician had cut him off of the Percocet because he was supposed to start on a buprenorphine regimen the next day, and someone in his entourage went and got Percocet off the street, and it turned out to be fentanyl. So why fentanyl? Well, it's easy. They can make a hell of a lot more money. We've got pretty decent chemical control in this country. In China, that's not quite the case. The chemicals needed to manufacture fentanyl are readily available in that country, in that part of the world. So, there's something called the dark web. I've never been there. I find Google challenging. But there's this place called the dark web, and if you know how to maneuver that thing, and you know what a Bitcoin is, and I still have never figured out Bitcoin, but if you know what that is, you can go online and get a kilo of 99% pure fentanyl for $6,000. If you mix that with fillers and binders and sell it as heroin, for that $6,000 investment, you can make $1.6 million. Because it's that powerful. Fentanyl is that powerful that you've got a whole lot of binder in there and just a little bit of fentanyl if you mix it right. If you want to go a little further, go on eBay. For about $500, you can get you a pill press. If you want to spend a little bit more money, you can get you some dyes to make your pills look like a Percocet 30, a Xanax bar, whatever you want. The potential profit from that is $6 million for that $6,000 investment, whatever you paid for the pill press and dyes. This is a business model that's not going anywhere. Fentanyl is our new norm. We wanted to get rid of heroin. Well, careful what you wish for, because we got a whole new game in town. How are we going to deal with this problem? Well, we got to do a better job of public education. We got to do a better job of getting patients and getting the public to understand that opioid addiction is real, the risk is there, and they need to know that before they just enter into that kind of therapy. We've got to increase the access to treatment for those that are addicted. It's not enough to say we don't have enough treatment. We don't access what we have very well. And I'll talk a little bit later about how I hope to fix that. But someone in active addiction does not have the skills or the ability at that point in time to sit down and make a good logical decision about what's the right type of treatment for me and how can I access that and where can I go. And they're not going to sit on the phone and call 26 places today to see if anybody's got a slot open. So we're going to need to do something to fix that. We enhanced the penalties for major traffickers. For heroin, we need to do the same thing with fentanyl. And we've got to continue to work on naloxone access. It does save lives. And we've got to continue to push that. So 2015, we passed Senate Bill 192. It did a lot of things, but mostly it's a harm reduction bill. We've created a Good Samaritan provision. It says if two people are using together and one of them overdoses, if you call 911 and stay with them, if you've got a small amount of drugs on you or paraphernalia on you, you won't be arrested. Some of my colleagues from the law enforcement world don't care for this, but I've sat with too many mothers and too many fathers who their child was using with a group of friends. They overdosed, they all scattered because they all thought they were going to jail. I'll submit to you that if they're using heroin together and they're overdosing, they're probably no stranger to the criminal justice system. We'll see them again. They just get a pass this time. And hopefully we can talk them into treatment. With naloxone, we had worked on naloxone language before, but we still couldn't get prescribers comfortable with widespread prescribing of it. And where it says a person or agency, that used to say patient. And that's why doctors were hesitant to just blanket naloxone going out to whoever and whenever if they didn't have that doctor-patient relationship. So I understand that. So we got them to change the word patient to a person or agency, which means you can prescribe it to anybody. We put in a lot civil and criminal immunity, so you can't be held responsible if something goes wrong. This is the only drug that we allow pharmacists to both dispense and prescribe. If they've gone through some training and they have a collaborative agreement with a physician, we can push this thing out through the pharmacies. And our pharmacists have really jumped on this. Rite Aid, CVS, Kroger, all are carrying naloxone now. We've got almost 1,000 pharmacists that have taken the training, a lot of retail independents. They've really taken ownership of this. I'm proud of them. The most controversial section of Senate Bill 192 was needle exchange. And a couple of times I thought we were going to have to drop it out of the bill. But my new boss, Secretary John Tilley of the Justice Cabinet, was at that time chairman of the Judiciary Committee in the legislature. And he had had an LRC staff do a lot of research, and he said, no, this is the right thing, and we're not dropping it out of this bill. And the same time we were debating that, over here in Indiana, 30 miles up the road, there was another drama unfolding. And had it not been for that, I don't know that we would have got this passed. But what the legislature did as a compromise was said, first the Board of Health has to come up with a plan and want to do it. And then they've got to go to the city government where they're located and the county government and get it approved. There is an upside to that. It gets people in communities talking. It gets the local newspaper writing about it. It gets the local radio station talking about it. Because we cannot continue to ignore this or stigmatize and sweep people under the rug and think they're going to go away. We got to deal with these things. We got to meet people where they are. And I think this, because of this conversation that has to occur in a community before they can have needle exchange, makes a community more ready for it. I'm going to skip through a couple of things here. We did create some tougher penalties. We said 2 grams of heroin is a class, for a first offense, is a Class D felony, 1 to 5 years. But if the prosecution can prove signs that you're a commercial trafficker, maybe you only had 1.5 grams, but you had $6,000 in your pocket, and you had some scales, and you had some packaging materials, that's a commercial dealer. Then you're going to have to serve 50% of your sentence instead of the 20% that's more typical. Selling 2 grams up to 100 grams is a C felony, 5 to 10 years, and those trafficking in more than 100 grams is a Class B felony. And we've actually had several of those in Kentucky. We created the offense of importing heroin, and that's a separate offense from trafficking in heroin. So in other words, the police arrest you for trafficking. If they can prove you brought the drugs into this state from another state with the intention of selling them, that's a separate and distinct felony. And my friends in Northern Kentucky are loving this charge because they got people coming back and forth across that bridge every day with heroin. I'm going to propose that we add fentanyl into this in the next session. Then the legislature did something in this bill that they never do. They gave us some money to help fight this problem. It was $10 million in 2015. In Governor Bevin's budget, he requested $15.7 million, a big increase, in the first year, and $16.3 in the second. And it's remarkably stayed in the budget. So we've had some good resources. But what the legislature told us is we want you to divide this up among some program areas. We want the Department of Corrections to provide some treatment in local jails for non-state inmates. Right now, or prior to this bill, the only people that could get treatment were state felons. But we can expose more people to treatment in prison or in jail settings by this classification. We gave money to DOC for its state inmate program. The largest treatment provider in the state of Kentucky is the Department of Corrections with over 6,000 clients. So it takes some money to do that, and we were able to help them out with that. We started a pilot program in the Department of Corrections where people that are coming out of custody with an opioid use disorder If they want to take a Vivitrol shot, we'll give it to them that last day or two they're in custody. Well, then, if they're eligible, we'll get them signed up for Medicaid to continue that treatment. It was slow getting started because they spent a lot of time figuring out the rules and regs and the policies and procedures needed. Started giving the first shots in March of this year, and it's been steadily growing. So what we hope to do is look at people with an opioid use disorder that came out without a Vivitrol injection and those that did, and was there better outcomes for the people who took the shot. We all know that coming out of a sober environment and going back to using is the time most dangerous for an overdose death. So that's kind of the thinking on this. We had money to give to our community mental health centers. We now have about 8 of our community mental health centers out of 14 that are doing medication-assisted treatment. They're stepping up their game. They're getting more involved in substance abuse treatment, and we're able to give them some funds to do that. What you're talking about, neonatal abstinence syndrome. We were able to give funds to Volunteers of America's Freedom House and Chrysalis House in Lexington and the Independence Center in Corbin and a number of places that work with moms and babies. We're able to provide some funding to last year and again this year. Then there's money for what's called the Rocket Docket program. This takes prosecutors, puts them in the district court. When somebody comes through with a low-level felony, if they can work out that, that they have an opioid use disorder, we can get them into this treatment program and hold this felony off. And if you can successfully treat this, complete this program, we can do away with this charge. They've had about 1,600 in the first year that they diverted. The cost savings on that was certainly in the millions. And they've got a lot of people into substance abuse treatment. So it's a good program. The Department of Public Advocacy, they have social workers that are co-located with their attorneys. Social workers will go into the jail, talk to the client or the inmate, figure out why are they revolving in and out of this. Do they have an addiction issue? Do they have a mental health issue? Is it chronic homelessness? What are some services we can provide so they stop going through this revolving door of justice? And then they'll get with the Rocket Docket worker, and the social worker will get in there, come up with an agreement to keep this person out of prison and get them the services they need. And it's showing a lot of promise. And then Kentucky ASAP is in my office, and there's some funds that go to my office. We're reviewing grants now for 40 community groups, community anti-drug groups, to do programs at the community level. And it has to be around opioid prevention and treatment. So I think we've done some good things. And there's more to come. My friends at the Kentucky Injury Prevention Research Center, we worked on a grant together, and they've got a grant to build the best treatment slot locator we can come up with. And it's going to be geared toward folks in medicine. It'll be for a primary care provider to have his staff go and find out who in Kentucky is doing buprenorphine treatment and has a slot available today. Who's in the recovery programs that's got a slot open today. So it's going to be very interactive. We're going to be coming out and selling it to the medical community. We've got money to hire some outreach coordinators. So we'll be in the emergency departments and in the hospitals and the big primary care practices saying, please use this service. Then the other thing we're trying to do, because let me back up, because I hear from providers all the time how difficult it is to make a referral and how much time it takes. Hopefully this will speed that up greatly. But that's only one side of the equation. Because a person in active addiction probably is not going to be able to manage this website. As I mentioned earlier, they may not know what kind of treatments are available, because we throw that word out, treatment, but that means so many different things. And so many different programs that don't all look alike. nor should they. But we're hoping to create a substance abuse treatment, I don't want to call it a hotline, we'll call it a clearinghouse, where a person in active addiction or their family can call, get an assessment, have some conversation with a peer counselor that can really get into, okay, Bill, you say you went through this, you've been through intensive outpatient 3 times, it didn't work for you. Why do you think that not work for you? Is there something else we can try? Are you interested in medication-assisted treatment? Are you interested in a residential program? And try and help people make good decisions, not make it for them, but just try to give them the information to make decisions. To be able to, the folks that are manning the phones will also have access to this website and can help locate those programs. And I'm hoping by doing those 2 things, no, it doesn't increase substance abuse treatment, but it increases the smartness in how we use it and utilize it, and how we get it to people, and how we get people information. Because this problem's going to be with us for a long, long time. It's going to be with us for a long, long time because if you look at the slide up there, we use 99.3% of the world's hydrocodone combination products with 5% of the world's population. We use 82% of the world's oxycodone products with 5% of the world's population. Until we change those numbers, this is not going anywhere. We can pass all the laws we want to in Frankfurt. We can do all the things we can think of to reduce the harm. But if these numbers never change, this problem never goes away. I'm glad that we're starting to get some attention in Washington, D.C. now on this issue. But I'll tell you, Congressman Rogers was trying to get people to pay attention in 2004. I was on a panel earlier in the week speaking at an event over at the Hyatt Tuesday, and Mary Bono, who used to be a congresswoman, was on the same panel. And we've known each other for a number of years, and she's a real advocate on this issue. And her and Hal Rogers formed a prescription drug caucus in 2006, saying we've got to address this problem. And now we're finally getting there, but boy, it's been a long time coming. It just seemed for the longest time there were a lot of stakeholders that just didn't want to get involved or just didn't think it was their role. That's changing, and I'm excited about that. I try to be a glass half full kind of guy, but I got to tell you the truth. I don't think we can fix this problem until we fix this problem on the screen. I've got about 5 minutes left. If anybody has any questions or comments, I'd be glad to entertain them. My contact information is up there. If I can be a help to you, if I can get you information, anything I can do to help you, I'm always glad to do that. And I'm sorry I get so preachy, I just do that.
I just have a couple of questions, one for you and one to piggyback to Matt. So my question is working with DCS, and it could just be my age or my ignorance, but I'm going to say my age because I'm that young. Not. Anyway.
I just said my wife's been a nurse for 35 years, and they told me this was going to be online, so that could be a problem. She started when she was 12 years old. I want everybody to know that.
There you go. That's a good cleanup. But tell me, when I think about heroin, I think back during the Vietnam when people were coming back home and injecting and using, and then as a teen in the 80s and 90s, the epidemic was crack cocaine. So what was the big change from smoking to from injecting to smoking to injecting again? Is it just the different high that you get, or because it seems like...
That's a really interesting point. Let's talk about that a second.
Okay.
People came back from Vietnam addicted to heroin. Most of them quit because there weren't any other opioids. The heroin availability that they had in Vietnam wasn't equal to what was available on the streets. And we didn't prescribe opioids in the 70s, only to people who were dying. So what changed is the availability and the existence of and the overexposure to opioids led us to heroin this time. It wasn't a war in Southeast Asia. So that's the difference there. The crack cocaine epidemic, that's when I was policing, and it was nowhere near as big as this is. But the distinction in the type of high is completely different. Methamphetamine and cocaine are stimulants that cause great endorphin releases. It makes you feel really good, and, you know, that kind of thing, where heroin is a totally different kind of euphoric rush, but not this high energy thing.
Okay. And then, okay, that's fine. And so then the treatment facilities, what we run into big in the Department of Child Services over on the Indiana side, is that you have a client who is ready and willing to go right then and there, but then you don't have any openings, or you have to have not used for 24, 48 hours, 72 hours. These people don't have that time. No. And then, I mean, because they just don't have the time. It's either do or die. And that's the big problem with treatment facilities, is that they may or may not have these openings. If they do have these openings, you have to stay clean for so long. You can't take this, you can't take that. That's a huge effect on, I mean, that's a big deterrent.
Yeah, and that's the whole logic behind the slot locator and the clearinghouse, is when people are ready for help, if you can't give them to them, waiting lists don't work. You're not going to be in the same place mentally 2 weeks from now that you were in that day you were ready to accept treatment. So we're hoping to expedite that process. Another thing that I keep talking about, and I've met with some hospital folks, is to think about buprenorphine initiation in the ER after an overdose. If we could get people stabilized on buprenorphine right after an overdose, that buys us time to, if they're willing or open to treatment. Because why do people want to get out of the emergency room after they overdosed and got hit with naloxone? They don't want to get dope sick. They want out. I want to use. But if we could give buprenorphine, we keep them from getting dope sick. It starts to buy us time. A couple of states are experimenting with this, and some hospital systems, and I'm hoping it's something that we can take a look at in Kentucky as well. I got time for one more, and I apologize. I never do this, but I have a meeting in Frankfurt at 4 o'clock I have to be there for, so I'm going to have to run.
It's a quick question. You're providing the Vivitrol injections in the state prisons. What about in the county?
We are partnered with about 8 county jails to do the same thing. And we could partner with more. There's just not been more that had a lot of interest.
Because we've had 2 moms come through New Visions, you know, stabilize on Subutex, old records come up, been put back in prison, and then they're getting Tylenol with codeine, Norco, you know, 2-3 times a day in jail. Yeah. And in the same situation, they started over.
Yeah. Yeah, we are partnering with some jails and hope to partner with some more. Again, let me thank you for what you're doing, for caring about Kentucky's moms and Indiana's moms and babies. Hopefully we'll someday look back on this and say, wow, that was a hell of a problem we went through in the 2000s, but it's over with. I hope I'm alive to say that someday. Thank you all very much.